All right, welcome. Today we're going to go over Chapter 34, Multisystem Trauma. We'll be covering multisystem trauma and managing the multisystem trauma patient. So multiple trauma patient is just a patient that has more than one serious injury. Multisystem trauma is one or more injuries serious enough to affect more than one body system. Teamwork, timing, and transport decision are key to proper patient management. So determining patient severity, most critical decisions are patient priority and severity, whether to limit scene time or not, and which hospital or transport method is best for your patient. So depending on what you have going on with your patient, limiting scene time is almost always the right decision in a trauma patient, and then obviously transporting a patient to a trauma capable facility, and then whether or not that's best for the patient to do by ground, an ALS intercept, or requesting a helicopter. So some determining severity, there are some physiologic criteria for what is considered a priority patient. Altered mental status, so a GCS of less than 14 with a head injury. Hypotension, so a systolic blood pressure of less than 90 could indicate shock or internal bleeding. Abnormal respiratory rates, so whether that's really fast, really slow, or an irregular rate and depth, could indicate head injury and could be present in later stages of shock. Some anatomic criteria, an amputation proximal to the wrist or ankle, so anything in your forearm or calf would be indicative of a priority patient. Pelvic fractures, open or depressed skull fractures, paralysis, penetrating injuries to the head, neck, torso, and extremities proximal to the elbow and knee, so anything toward the body from the elbow and knee that's a penetrating trauma. Chest wall instability or deformity, 2 or more proximal long bone fractures, so your humerus and femurs. Crushed, degloved, mangled, or pulseless extremities. Some mechanism of injuries to consider. So in the absence of the anatomic or physiologic signs we just talked about, mechanism of injury is considered if it's severe. So falls, normally this is a fall from about 2 times the patient's height. So if the patient's 6 feet tall, a fall of 12 feet or higher would be considered a high priority fall. High risk auto crash, so things with intrusion, ejection from the vehicle, a death of another patient in the same passenger compartment. We don't really have access to vehicle telemetry data, but if you did, that consistent with a high risk of injury would be something to consider. So older patients do not effectively compensate for shock. Their body systems are slowly degrading, and a lot of times they're on a lot of medications that inhibit the natural reaction of the body. Children should go to a pediatric specialty facility. A trauma surgeon who works on adult patients all the time is not going to necessarily know how to manage a pediatric patient. Patients with certain conditions like those taking anticoagulants, patients that are pregnant, we need to make sure that we're going to a facility capable of dealing with the obstetric portion of the patient and not just the trauma portion. The trauma is going to kind of trump those things. If it's a multi-system trauma patient who happens to be pregnant, we don't necessarily want to take her to Hillcrest South where her obstetric doctor is. We would need to go to a trauma center. So a typical call. On page 1003 of your book, There's a scenario. The scenario is a 25-year-old male motorcyclist was involved in a accident, not wearing a helmet. The rider was found about 20 feet away from his motorcycle. On arrival, you see two concurrent serious problems. The patient is unresponsive and has gurgling respirations and has some apparent severe bleeding from his thigh. So when you walk up, you're going to see these things kind of instinctively, and when you go through your March algorithm or HABC algorithm to do your rapid trauma assessment. So what body systems would the EMT suspect have been affected by this patient's injuries? So he's unresponsive and has some breathing problems and is bleeding from his thigh. So we have a vascular issue, a soft tissue trauma issue, as well as a potential head injury with his level of responsiveness, gurgling respirations. What is the EMT's first decision about managing those injuries, and why would you make it? So he's bleeding and he's unresponsive and has an airway and breathing issue. Airway and breathing can't do what they need to do if the patient does not have blood. So the first decision should be to manage the bleeding. So put a tourniquet on that leg. And then we can get to managing airway and breathing at that point. So what actions would you take to support the affected body systems? So we've placed an effective tourniquet, the bleeding is controlled. Moving on to airway and breathing, we've placed an OPA, the patient is tolerating well. The patient's breathing labored at a rate of about 30 breaths a minute. So we will use a BVM and try to assist those ventilations, but only at a rate of about 12. What priorities would you set for this patient? So continuing with the trauma assessment, we find a hematoma to the right side of the patient's head. His neck veins are a little flat. There's no deformity of the cervical spine. Breath sounds are decreased on the right side of the chest. The abdomen and pelvis seem stable, unremarkable. You do find a mid-shaft femur fracture where you have the tourniquet on that right femur. The bleeding is controlled. You have pulses in both upper extremities and in your left lower extremity. We'll assess the patient's spine after we put a cervical collar on the patient and log roll them to a longboard. So through the rest of the scenario, the patient's mental status remains relatively unchanged, maybe a little bit better when you arrive at the hospital with some eye-opening to painful stimulus. His vital signs remained relatively unchanged throughout your transport. You get the patient to a surgical team and relay all your findings and interventions. So the previous scenario shows an example of a patient who has critical injuries. The primary assessment revealed several immediate threats to life that an EMT could do something about. So the EMT realized the seriousness of the patient's condition and did not delay transport and showed good judgment throughout the call. So general principles of multi-system trauma management. We need to determine roles for a multi-system trauma patient beforehand. Follow priorities determined by the primary assessment. We call this the golden period, not the golden hour now. We're not always capable of getting our patients to definitive care within an hour, but it is a good principle to remember that we have to limit our scene time and transport time. The patient needs something that we're not able to provide in these cases, which is surgery. So that being said, we need to limit scene treatment. So we get in and manage life threats. So the March algorithm is the one that I prefer to use. Massive hemorrhaging, airway, respiration, circulation, and head injury and hypothermia. So on top of that, we do need to stabilize the cervical spine when indicated. Be prepared to suction the airway, insert a basic airway like an OPA or NPA, ventilate with a BVM, administer oxygen, and then restrict spinal motion when indicated. Scene safety is paramount. We can't do any good to the situation if we are hurt ourselves. Ensure an open airway, perform any urgent or emergency moves as necessary, and adapt to the situation. We do have to be adaptable. We have to use ingenuity. Very few of these calls are, cookie cutter. This is the same as last time situation. Pediatric considerations. Pediatric patients will need additional emotional support because younger patients may not understand what is occurring to them and around them. When deciding whether spinal motion restriction is necessary, many protocols add the consideration of mechanism of injury. Pediatric patients are not always capable of explaining everything to us as if they were an adult. So trauma scoring, this is a numerical rating system for trauma. It assigns a number to certain patient characteristics to create a score. It kind of objectively describes severity. It helps determine transport to a trauma center or local hospital and helps trauma centers evaluate the care of similar patients. So the components of the revised trauma score are the GCS, systolic blood pressure, and respiratory rate. Follow your local protocol for use of the trauma scoring system. This is normally something that's kind of done after the call. If we wanted to look at it, it's easy. We're going to look at a form here in a minute. But this is not something that's important enough to let interfere with patient care. It's not something that the hospital is going to ask you for. When you give a report to the hospital, you are going to give them a GCS, a blood pressure, and a respiratory rate, and they can create their own revised trauma score from that. Not something that we need to be thinking about in the moment. It's not going to be anything that dictates patient care. Here's an example of the revised trauma score. I can let this here for a second so you can pause if you want to look at it. So the three characteristics are a 0 to 4 scale. So they can get as few as 0 points and as many as 12 points. Chapter review. Multisystem trauma is a serious condition in which two or more major body systems are injured or affected. Recognizing multisystem trauma, triaging properly, transporting promptly, and choosing the correct destination are vital for the survival of your patient. The CDC has issued guidelines for trauma triage and transport. These are a guide and should be used in conjunction with your protocols. The revised trauma score is one method of classifying trauma patients by severity and includes the GCS, systolic blood pressure, and respiratory rate. Remember, your primary assessment should determine whether your patient is seriously injured or potentially seriously injured. Limit scene treatment to life-threatening conditions. Use patient severity like physiologic criteria, anatomic criteria, and mechanism of injury to decide whether to transport to a trauma center or local hospital. Some questions to consider. Is my patient seriously injured or potentially seriously injured? Should I expedite my scene time? What is the most appropriate transport destination for my patient? Critical thinking. A patient was involved in a car crash with significant intrusion into the area where the patient was sitting. The patient is alert and complains of pain in the ribs. Has a heart rate of 96, it's regular. Respirations are 30 and adequate. Blood pressure 100/62. Pupils are equal and reactive. Skin is cool and dry. So you need to ask yourself, does anything stand out right there? It's not all the information you would be getting, obviously, as you arrive and start asking questions and doing your assessment. but 30 breaths a minute is elevated. So if you think about what kind of trauma could that indicate, could have something to do with chest wall trauma, but we won't really know until we get a further assessment. Your partner says the patient is stable and could be easily transported to the community hospital nearby. You think the patient should be transported to a trauma center. How would you justify your decision to your partner? So since that patient complains of rib pain and there's a high potential for blunt trauma injury to the chest, we don't know what's going on. And if we take that patient to a community hospital, they may not have the equipment necessary to determine the severity of the injury. So the transport decision should be to the trauma center who has the capability of caring for the patient.